this is not that. So 4 of those 5 are bleeds. Those people get admitted to the hospital. They're going to get evaluated by neurosurgeons, maybe hemiectomy to remove that blood, maybe just a drain. That's a whole different service from what I work for. The bottom left, you can see the dark area there on the right side. That's ischemic stroke, but it's old and it's huge. I don't know how long it's been there. It takes about 4-ish hours for stroke to show up on CT. So we don't want to see it on CT because we know it's at least 4 hours old. And then potentially longer than that. And that all goes back to what's the last seen well. And we still get it that, oh, it was just an hour ago, it was sudden onset, and then you see something like that, it's like, no, that's not right. So we want to see just a really nice, clean, plain brain, because that means that we can potentially still do treatment on it. That means we can do 1 or 2 things to it. So we want to see a nice, clean, plain brain. So with the stroke order set, after we shoot this image, they just call the results right to us, to our cell phone, to our ASCOM phones from the radiologist in about 5 minutes of what their findings are, and then we proceed from there. During the day, we have our own stroke hospitalists, Dr. Shepard and Dr. Krishna, and they work 7 on, 7 off, so they flip-flop each other. And then they each have a nurse practitioner with them. And so you guys paint a really good picture. It gets to us, we call the nurse practitioner. She comes down, goes through the whole process with us. She'll get right up to the point of offering clotbuster medicine, and then the physician will come down and we'll go from there. So, if they need advanced imaging, this is what they call a CTA or CT angiogram. It's very much like the plain brain, except they throw contrast in the IV and it lights these pipes in the front, pipes in the back up, so they can see if one of the bigger pipes is blocked, one of the larger vessel pipes is blocked. And we'll do that anywhere from the last seen normal time up to 6 hours or so. And then if they're over 6 hours, but less than 24 hours, we'll do this thing called CT brain perfusion. And this is really cool software. It's very much done like the CTA. They throw contrast in there. It doesn't even go to our radiology department. It goes off-site to a third-party vendor, and it comes back to us. We have an app on our phone, and it looks just like this. So if you can imagine cutting out all those pieces, all those brains, and stacking them on top of each other like arts and crafts, the pink is brain that we're not going to be able to salvage. The pink is ischemic brain. The green is salvageable penumbra, or salvageable brain, if we're able to remove that clot. So you can see how much brain is there left to potentially save. It's quite a bit. It's almost half that whole hemisphere. So this person potentially might, not going to get all to place because we're outside of the window here, but they're going to go to the neuro lab and we're going to pull that clot out. So, okay, there's the app. Go get it. It's really handy. Totally free. Love it. This is clotbuster medicine. Okay, so you can give but not you. You can give clotbuster medicine up to 4.5 hours after the last seen normal time. And it's the most potent blood thinner out there. It's the only medicine at St. Francis that we have that you have to sign a consent for right before you get it. And so the downfall to clotbuster medicine is it's not going to make one clot go away in your body. It's going to make all the clots in your body go away. So we figure out sometimes that they're trauma patients just once the clotbuster medicine is circulating. There's a roster too down there. So you, if there's an IV miss that we don't know about, we'll see it because it's gonna blow up with the clotbuster medicine. So it's given over an hour. It's a weight-based medicine. Once they become eligible for it, we get a consent sign. That is what the stroke nurse does. We administer this medicine. We do the math on it. We actually have a stroke pharmacist during the day that helps us when she's available. But they get a 10% loading dose in the first minute, and then the rest of it runs over a course of an hour. And they sit down in the ER, and we are their bedside nurse in the ER while that's being administered. So it came about in 1995. The FDA approved it, and from 1995 to 2016, there was no other stroke treatment for those 20 years. Before clotbuster medicine, there was no stroke treatment at all. Even in the 90s, it was physical therapy, occupational therapy, and speech therapy, and let's hope they get better. And then Clotbuster came out. It's the standard of care. And again, nothing since then until 2016. So, inclusion, exclusion criteria, it's not something you have to commit to memory, but if they have any recent head bleeding, any recent major surgery, if you've had very large abdominal surgery in the last week, we're probably not going to give you Clotbuster medicine. That's just not going to work out well. So, but again, not anything that you guys have to figure out, but you just bring them to us, we'll do the heavy lifting. So. Anybody that gets Lisinopril or an ACE inhibitor, and we go get Clotbuster too, this is definitely a potential side effect, this angioedema. Their lips and or their tongue will swell up really bad, which could definitely become an airway problem. So if you've seen us in the hospital rolling around with our IV poles, stroke team, we have a blue bank bag out there. It's just a kind of double-sized bank bag. And in it we keep our Clotbuster medicine, a flush bag, some blood pressure medications, but we also have an EpiPen, Solu-Medrol, Benadryl, in case something like this starts to go down. We hope to not have to use the Epi because of what it does to the pipes and what we're trying to do to the pipes with the Clotbuster medicine, but every now and then we'll pre-treat Solu-Medrol and Benadryl in an effort to prevent this. So. All right, so like I said, there's no, this is what they came up with. Now we have, this is like Coke. We have Coke, Pepsi, Mountain Dew, Dr. Pepper. We got 4 or 5 different brands of this. This is the Stryker brand. Okay, so if you can imagine, obviously not to scale, but this is the clot in that large vessel. Okay, they're gonna run this right up to the base of the clot. Okay, and the way they do it is they go through the femoral artery, up the aorta, around the arch of the heart, and then up whichever side they need to go to in the internal carotid artery. And they run it right to the base of the clot. And then this is the real star here. See this chicken wire looking stuff? So Tyler, take your hand and cup it like that. Just kind of cup around it and then blow really hot. So that expands quite a bit. The metal is called nitinol. It was developed by the Navy. And so it can actually control the rate of expansion. And I want you guys to do that. Let it sit in there for just a minute. And then you can just push the back wire. This device right here, our demo, is actually not even a demo unit. It was a real unit we just took off the shelf to build. That's probably the 500th time we've done that. And every time it works. So it's amazing. And so you can't feel it, but on the outside of it are like little burrs. If you ever run through the field with your socks, you get those little burrs in your socks. It's got that on the outside of it. So they push it up into the clot and they let it bake, or they let it sit there and expand for about 5 minutes. And then it comes time to pull it out. So they do their own imaging in the Neurolab suite, and so they have AP and lateral view. So depending on which side they want to look at, they have this going on, but if they want to look at the other side, they just change it to this. And so they have an AP and a lateral view, depending on which side they're working on. So they throw a bunch of contrast in there, and the pipes become dark in color. And then the first thing they do is invert it. So those pipes that were black are now white, okay? And so they take a still image, and then they put the live image down on top of it. So they build themselves a roadmap. And as they're going up, they know that there's going to be a twist here, and there should be a road there. There's not. So the little twist here, the little roller coaster, that's called tortuosity. And every time there's a loop and a twist and a turn, it takes out length of that. It also takes out the tension of the twisting. So they don't want a lot of this, but they deal with it. And then just having the knowledge of the brain going, there should be a road there. And so they're going to take, like on the far end of that wire, and they're going to push through, because everything is just a build. So it's a wire with a hose on top of it, with a hose on top of that, with a hose on top of that. They're going to push through. So there should be a road there. So there's your problem. Okay.
And they'll do this in addition to the clot?
To the clotbuster medicine? They can. Yeah, a lot of patients get both. So the clot's up high. We want to pull down low. We got high pressure blood pushing up against it, going high. So if you notice on the left, they inflate that big balloon in the internal carotid, and it just shuts down blood supply to it. Just shuts down whatever side they're working on. They hook, wherever the device is, they hook a syringe to it and to pull a vacuum. And they also hook suction to it. And then they pull the whole thing out. So if a piece breaks off, it's going to come out anyway because of the vacuum and the suction they've got going to it. You can see the little chicken wire up there in that top right. It's getting ready to come down. And then once they pull it all the way out, they let the balloon down, they let the blood go back up in there, and they throw a contrast in there and take a photo, and it should light up more than what they had previous. Okay. In 2019, we did 110 of these. Yeah, which is amazing. We never expected that number to be so high. Our clotbuster medicine was always the top thing until last year. We only did the clotbuster like 92 times, and we did this 110. So now some of those are the same patient getting both, but it was a huge number to hit. So it's almost every third day, in theory, we're doing it. So with amazing results. So at the hospital, we use the NIH stroke scale. It's long, it's involved, it's in depth, it's subjective. You have to have cards and pictures and sentences to use. It's not something for the field to use. You guys are using Cincy or LA, or where you can get a nice positive, negative, inconclusive stroke scale, and that's perfect. Keep doing it. Everybody in here is everybody in here is a 0. 42 is we're dead. Okay. Start getting up into the, like, if your left arm is flaccid, completely flaccid, it's a 4. You have the leg in there, now you're at 8. If you're altered, you're up to 10. If you're without any speech at all, now you're up to 17. It builds quick. Right? So you get 0 to 10, and you're probably gonna go to rehab, maybe get to go home. You start getting up to the teens, we start worrying about airway control, swallowing abilities, things like that. You start getting up to the 20s, you start talking, you're gonna be in the nursing home for the rest of your life. You get up into the mid-20s and the 30s, you're gonna be a paid vent at the nursing home. And so, whereas you were maybe a 0 to start with, we can potentially do alteplase, potentially pull this clot out. It may not get you back to 0, because if damage is done, but it may keep you out of the nursing home, right? And I think everybody would rather be at home using a walker than be at the nursing home, right? So, a couple of just little case studies here. This lady's 57, her NIH score is 12. And so she's got some right-sided deficit. She did not meet criteria for alteplase. So you can see picture 1 and picture 3 go together, picture 2 and picture 4 go together on the APM lateral. So she was in a bad way on that left middle cerebral artery, and they were able to run up there and get good blood flow restored. She discharged a couple days later, 4 days later, 2 days later, didn't have it, as a 1. And that 1, I think, was sensory deficit from arm to arm. It felt different. And she was still completely functional. So, and you can see a picture of the clot up there. We got some other clot pictures here in just a second to look at. This lady's in Fort Gibson having lunch, has a stroke, falls over, gets a little whack on her eye. EMS takes her down to St. Francis Muskogee. St. Francis Muskogee gives her clotbuster medicine. They get the aerovac helicopter involved, they fly her up to us. We take her to the neuro lab. They're able to pull that clot out. She was initially a 13. She discharges home as a 1, but that little whack, which didn't even require a suture in the beginning, after clotbuster medicine, it looked like Mike Tyson had hit her. Just because we took out all the clotting factors for an hour, and it just big old hematoma. So, but she did really well. It was nice to have a lot of people involved in that, from Muskogee County EMS, Aerovac, St. Francis Muskogee, our team. A lot of people, laid hands on her to she left after 4 days, which is great. And then this is kind of our most recent shining star from last year. 46-year-old dentist. He's playing indoor soccer. Starts running towards the sidelines, grabs his right arm, and then before he gets to the sidelines, he collapses down. They call 911. It's in Tulsa. One of the Tulsa engine companies gets there. They start doing their thing. They're waiting for the game to end. For the next game are 3 off-duty broken arrow firefighters that have been through this. They come over and they guide EMSA to send him over our way. Nicole, my partner in the office, she and I, we get to see him right off the bat. We do clotbuster medicine on him, send him up to the neuro lab, and he was at 18. So he had pretty much no speech, and his right side was flaccid. And at the end of it, a handful of days later, he was had just a little bit of speech difficulty. And the next week, he was back to the soccer field. He's back to practicing his dentistry. So as an 18, he's probably going to be at the nursing home if that's not fixed. So again, not back to zero, but he's able to go out and make money for his family, keep his business open. That's a huge, 46 too. So, yeah, this week we've had 2. So I worked Monday, Tuesday, Wednesday. So Monday we had a 27-year-old that we took to the neuro lab. We gave him clotbuster and took him to the neuro lab. And his big thing was he weighed 508 pounds, and so that was quite a challenge. And then Wednesday, they flew one in from Muskogee that they had started Alteplase on in Muskogee, and she scored a 26 or 24, way up high. Like, you start talking like trach, peg, vent stuff if we don't intervene on this. And so they both had clot retrieval. The one on Monday ended up getting intubated just for sheer size of him. Just that whole lay flat, let's let blood flow go to your head, but you're so large, you're a thought man. So he ended up getting intubated. And I haven't checked on him today, but we're taking a lot of people to the lab to pull clots. So it's a happening thing. When our interventionalists are not doing emergencies that we bring them, they do a lot of scheduled cases. And so kind of like, if you can imagine like a diagnostic heart cath, we're just doing it in the brain. Hey, let's get up there, scope around and see what's going on. Which I make it sound like an oil change, like it's just that easy, but that's what they do. This was found on an incidental finding here. You can see on the far left, that's a basilar artery aneurysm. And so I don't know what this patient's complaints were. I don't know how they ended up getting the imaging. But what they did was they ran a stent up there, picture 2, and then they fill it with basically bird's nest or wire, really soft wire, way softer than that stuff. And they just fill it in, and you can see on picture 3, it's almost all the way gone, you can't even tell. And so that's one of those aneurysms that ruptures. If it ruptures, she dies. So they went in and fixed that. And that's probably a 2-night stay in the hospital, and then you get to go home. So, here's a picture of a few clots. If you can imagine the size of the device compared to the picture up there, like something this big is really messing up your world. So the bottom 2 are still attached to the device. The top left was probably one piece at one time until they ran it in the water. They run it in a little water bucket to see what comes off. It was probably one piece at one time. And so that top one, it's red and white. It's got plaque mixed with blood. So the clotbuster won't work on the plaque. It's not like blood, but like earlier, no one's got a lot of hair in here, but like Jeremy was here earlier. Long hair, lived in the same house for like 10 years. All of a sudden the shower backs up one day. You go out and get some Drano, liquid plumber, you put it in there, it works a little better for a day, but then it backs up again the next day. You go in there and get a plumber to snake out this big ball of hair. That's kind of the same thing. Our clotbuster will soften up some of these large clots, but it won't eliminate them. It'll make them soft enough to get the device into them and pull the clot out. If it's pure plaque that's in there, and again, not to scale, but our interventionalists sometimes will have to run the wire up there and literally chip away at it, which I'm sure feels weird in your brain as they're chiseling out the vessel. So
I've never had that.
Do what?
I said, I know what it feels like when they shoot a laser through your eye.
Right.
It makes the back of your head pop. It's kind of weird, but I've never had that.
Yeah, I can't imagine what the feeling is, but they, you know, if they're not intubated and knocked down, they can feel.
Yeah.
So, but, this is just a 3D image, and there's one little problem on there. If anybody wants to guess where?
The blue arrow.
Now.
That was a good try.
It was great, David. Good try. We took a picture and we found 2 arrows in there.
So nice playing Cowboys.
That little pinch point there. So probably an incidental finding, or maybe they came in with minor complaints of headache, blurred vision, something like that. Everybody gets a scan, and so they go in and go, oh hey, you've got this vessel. It's got some pinch point down. So this is that same patient, just in a 2D view, and this is that point here. So they've run their guide wire all the way open around, and they're going to go in there and stent that, and then here it is now, nice and painted open. So like I said, our interventionalists, they stay busy. You know, they're doing about 2 cases a day during the Monday to Friday hours, on top of whatever emergencies we're bringing them. So Monday when I took them, the young man early in the morning, I know it shifted their whole day because they had 3 scheduled cases. So they started their last case at like 7 o'clock at night. So, and then this is where you guys come into play, all right? The drill is always fun. That's probably the thing I miss the most, being a medic. And then the EJs. And so for us to do all of our imaging, our clotbuster, our antihypertensive medicine, reality, all we really need is that. 2 20s, 1 in the AC. So with our contrast, if this is the insertion point for the contrast, we're not going to get to see anything in the neck. It's just going to be one big white blob. So we can't run our contrast through that. The contrast and the drill don't go together very well at all. And so if you bring like 1 in the hand because they're a hard stick, the reality is we're going to go get a second one somewhere, just between doing clotbuster medicine, blood pressure management, contrast. We're going to have to find a second source. And so, and then if our neuro guys don't really like them intubated, but by all means, if you have to intubate them. If they're not going to be able to control their own airway or they're vomiting, drooling, don't hesitate to intubate them. It's just going to take a little longer for us to see the results. And so if you've been in when they do the heart cath and you get the gentleman on the table and then all of a sudden they open that vessel up and they go, oh, thank God, whatever you did, thank you. Whereas when they restore blood flow to this, it takes a little bit longer. And then if they're on the vent, it's going to take even longer. But we would rather they had airway control. And we'll find out a couple days later how they did. What questions do you have? Bruce, what questions do they have?
Well, I have one since you just put a bunch of candy in his mouth.
I was going to ask what the airspeed was about.
Okay, he had 2 questions. Okay, and I don't even know where it's at for sure, but did you guys notice doing this stuff specifically at St. Francis, like when the state started pushing for having the outlying agencies go to the closest facility to have a CT done, as long as they could do the TPA? So I would do TPA or TPA, whatever it is. Did you guys notice a difference in that? Because I know that was a push for a while, but I don't know if it actually became an official thing or.
You know, and I don't go to a lot of those meetings purposely, but well, like from St. Francis South, St. Francis Muskogee, Bonita, Glenpool, anytime they start Clotbuster, they just send them to us to go to the ICU. Glenpool doesn't have any inpatient beds to begin with. South and Muskogee and Bonita will ship them to us. I can't speak to the other hospitals. I know Hillcrest, I think, at one time, Hillcrest South would keep them if they were minor strokes getting TPA. But I can't even really speak to that. But I think Jacob was here the other day, Pierce, and I think his dad was working over there and we were talking about it. So, but I don't know if that's still a thing or not.
Have you noticed any difference in your patient outcomes if they go to one of the outlying facilities and get that stuff started sooner? Does it make a difference?
I can't speak to it because I don't do that data, but
I was just curious about that. I know that was a push for a while. I don't even know exactly where it's at, you know, in the state.
Yeah.
If that's still something.
And we would like it to continue that way. We'd like them to get Clotbuster if they can get Clotbuster, because maybe like our Muskogee area patients, if by the time they drive to Tulsa, now we're outside of that Alta-Place window or that Clotbuster window, whereas if you would have gone to Muskogee to start it, then you could have driven or flown here.
Because for us, it doesn't really matter. We're close enough.
Right.
Whether we come here or go there, 15-minute difference. So I don't think it matters to us where we go.
Right.
We're gonna try to run them to Tulsa if we think they're gonna need something like this.
Yeah, absolutely. If you, I mean,
Facilities can't handle it.
you can look at it and go, I mean, you guys are all great clinicians. You can look at it and go, that's really a bad looking stroke. Not just, oh, my arm's kind of numb and my face is a little bit numb. Like, you're flaccid. You can't move that arm at all. You're slurred speech or without speech, or like, you can pinpoint that and go, that's not gonna be good. So we had one come from, I'll say, Northeast Oklahoma the other day, from a facility up there, and they didn't do Clotbuster on the lady for whatever reason, and then they called their local EMS, and they came, you know, it's like an hour and a half drive, and they came from emergency, came in, and hey, here's that lady, and meanwhile she's flaccid on the right, without speech. I mean, we scored her like a 17 or an 18. So, you know, it's just like, we could have, like, we should have flown her, or we should have used the woo-woos to get her a little faster, but we took her to the neuro lab, and she luckily had a really great outcome. But by the time they got to us, she was outside of the Clotbuster window time. And it's like, you know, and that started at a hospital. So
they could have made a big impact on her.
Yeah, and so she went home with some deficits, some minor deficits, but she was able to go home. But those deficits might have been erased with Clotbuster at the outline to start with. So,
Yep, the only other thing I would say is questions I've asked you in the past.
yeah, so family contact is a big thing.
Family contact,
Yeah.
phone numbers, yeah.
Yeah, so like I said, whether it be a Clotbuster Med Center or the neuro lab, we'll need a consent to do it. And if they can't speak for themselves, we'd really like to talk to a family member. And you guys you're great about, you know, putting it on the back of the rhythm strip or a separate piece of paper or wherever you're handing it to us at some point. Just when you type your ticket up, just throw it in the ticket as well. Because I audited that later, and I'm certain that you probably gave it to me at some point, or gave it to my partners. Just throw it in the ticket. And I send Bruce a fair amount of letters. I don't know if he distributes them. I'm assuming he does. So,
I walked through you now.
cool. So, what else?
No, when he sends them to me, I usually try and forward those back onto the crew so that they can see what happened with the patients.
I'm trying to send, like if they've got a bleed, I'm trying to send the bleed images back out, how bad the bleed is. Anybody that came in with 6 hours, you know, with that lasting normal to 6 hours, gets a letter. Whether they get a treatment or not, they get a letter. So last year we sent somewhere around 350 letters. And so some of them got treatment, some of them were bleeds, some of them were excluded from treatment for other reasons. You get Granny in the nursing home that's a bed-bound, Alzheimer's, dementia, Parkinson's, that has a pretty large stroke. We're probably not going to intervene on that, because what are we gaining back? She was already bed-bound, nursing home. You know, we start talking about pulling clots out of brains, and the side effect of that is them bleeding in their brain, and then that could potentially lead to a worse situation. And so, stroke in the beginning kind of used to be well, how old are you? Oh, we're not going to treat you because you're 85 or 90 or 90. But here's the reality: is now we do it all off how functional are you? Like we Clotbustered a lady the other day that was 96, lived by herself, drives, goes to the store by herself. She's just living the dream. And so it's like, she gets Clotbuster. She's an independent person. Age doesn't matter. And so, yeah. So it's all how functional were you prior to this event. So.
Have you ever heard or seen the cost of the treatment that you do?
So the Clotbuster, we buy the Alta-Place for somewhere around $7,500 a pop. and that's, you know, on a pallet from Sam's, you know, buying bulk. So, I mean, that's what we pay for it, give or take, that's what we pay for it. This, wherever that is, I don't know.
I didn't know if you had ever heard of what a patient's bill was after returning back, after being discharged.
I hope they have insurance, I hope everybody has insurance.
It doesn't go against your credit score anymore if they don't.
Oh, I think that's good.
So,
I don't, I know that, I mean, you guys know what the price of healthcare is, so, you know, that back there is a real device, it's not a demo device. It was made when the demo device was left somewhere else, so we made a real device become our demo device. And so, but I don't know how much that costs. And that's just a small portion of the system that they use.
between all the CTs and the MRIs and everything else,
Yeah.
70, 80, 90,000.
You're telling me or asking me?
I'm asking.
Oh, I don't know. I'm just gonna smile and tell you.
When I got my workup this year, obviously they didn't pull a clot out of my brain. They did all the complete workup and I was there for 3 days. And I believe it was, one of the bills I got was 40 grand that was paid. I got contrast and multiple contrasts, multiple CTs, ambulance trip from Johnson to Tulsa. I got the heart, angiograph thing of the heart. I got an EEG, multiple EKGs. I got blood thinners, not clot buster, but I did get blood thinners.
Aspirin stuff.
Yeah, it was 40 grand was one of them. So.
Yeah, so that's the thing. If you come into the hospital with stroke, not only are they going to treat the stroke if they can, but they're going to figure out where it came from. And so you're going to get your carotids looked at. You're going to get an echo of your heart. You're going to get an MRI. You're going to get a 24-hour CT to make sure that, especially with clotbuster, that they didn't bleed later. So I was talking to Bruce in between classes. So if you come in with stroke symptoms, and there's not a million, but there's a million things that mimic stroke, everything from seizure, blood glucose levels, conversion disorder, things like that, where you come in, you get clotbuster medicine, and then you go get a normal, you have a normal MRI, it doesn't show anything. One of two things happened. One, they weren't having a stroke to begin with, it was a mimic. Or two, the clotbuster aborted the stroke, and the MRI still looks normal. It's those that come in with symptoms, get clotbuster medicine, and then they go get a normal MRI, but they still have symptoms. It's like, what is that all about? It's going to be a mimic of some sort, or what it showed on the MRI. So, and it may be like a hemiplegic migraine. It may be maybe they've changed the name of conversion disorder just recently, and I can't tell you what they've changed it to, but like a psych thing. So, and that was, again, in between classes, we've got a lot of people coming in faking stroke. Back when I was riding the truck, you know, they were faking chest pain to get morphine, and now they're faking stroke because they know they're going to get one-on-one care, and ultimately they can go, well, my left arm or my right arm doesn't work as well. I'll take the clotbuster medicine because I know I'm going to get one-on-one care later, and then, oh, you know what, that right arm just hurts. What do you have for that? Well, I'll give you Tylenol. I'm allergic to Tylenol. I'll give you morphine. I'm allergic to that too. And so they're willing to get clotbuster medicine, which is, I mean, that alone could kill you to get, so, and it happens a lot where somebody will treat them, whether we treat them or they come from an outside facility, and they're in the ICUs where they go after clotbuster medicine. I'm still having pain in this, pain in that area, and at some point in time, they just, all of a sudden it works, and they get up and put their pants on and walk out. So, it's that's the way it is these days, unfortunately, so. Yeah. Questions? David, any questions? Well, if you guys don't have anything, I'm good. I got a bunch of notepads if you guys want